Welcome back to EKG, our second video segment here, which is going to get into talking about EKG itself and some of the general overview of what it is that we're trying to do with EKG. So let's get a shared screen here. All right, so when we talk about EKG, electrocardiography, let's talk a little bit about some history of it. First of all, in 1855, we found out that if we stimulated frog legs, sans the rest of the frog, if we stimulated frog legs that were not on the frog, we would find out that they would actually move. And we could find out that if we call that kind of an isolated beating heart, if we were to find ways to stimulate electrical activity on the frog, it would work. We found out there was a French scientist who discovered that if we remove the heart of a frog, but make sure that it has a sodium-based electrolyte solution around it, it could beat for as long as 30 minutes. And if we kind of changed up the type of electrolyte cocktail that it's in, it could keep beating outside the frog for as long as 2 days. So that was kind of our first foray into understanding that the heart has its own electrical activity and functions all by itself. In 1901, Willem Einthoven invented what is our first basic EKG. It was called a string galvanometer, and it was our first EKG. He's not the first one to really identify that the heart had rhythms, but he's the first one to kind of put it into a usable form for us. You'll see, I often call electrocardiography EKG. You'll hear it called EKG or ECG, either one. In the United States, we call it electrocardiography, spelled with a C. In Einthoven was German. And cardio is got a K in it when we spell out the word. So EKG and ECG mean the exact same thing. Einthoven ended up receiving the Nobel Prize in Physiology in 1924 because of what he created, and this is what he ended up creating. This is his galvanometer that he had. We would have a person that you see right here that would sit down with 2 arms and a leg in a barrel of ionized water, and from that he could print out a rhythm of the heart. Fortunately, we don't have to use a machine like this anymore. There's ways that technology has come far enough that we can actually see a different use or a different way of using that that's a little bit more efficient. Basically, what is an EKG? If we take some sort of a voltmeter or something that we can measure electricity from it, stick it with a printer, add $50,000 or so to it and a little bit of technology, and we get a monitor. That's a little oversimplified. Certainly there's a lot of bells and whistles that we get with our monitor, and they're much more accurate these days, but in the end, it really is just something that measures electricity and allows it to print out on a screen or paper or both, so that we can see a graphic representation of what the heart is doing electrically. Why is it important? It's important because of what I told you in the last video, which is cardiovascular disease is the leading cause of death in developed countries. What we also see is that when someone first has a cardiac event of some sort, let's say they have a heart attack of some sort, immediately after they have had the event, there's a certain amount of damage that's done to the heart, whatever that damage is. So a certain amount of damage is done. Then what we see is for about the next 70 minutes or so, it's relatively flat or a very slow incline, meaning the damage to the heart is relatively the same right after the event and for the next 60 or 70 minutes or so. But after about 60 or 70 minutes of having this heart condition continue, then what we see is an exponential growth in the damage to the heart. So the goal of an EKG is to be able to take a look at a patient, identify that they have a cardiac event occurring, be able to transmit that information to the hospital in such a way that allows them to bypass a lot of the ER testing related time that is spent when a patient first arrives at the hospital. The goal is that when EMS brings a patient to the hospital, if the hospital has already been able to evaluate an EKG of a patient, add to that the signs and symptoms that the paramedic has seen, then the hospital can get the cath lab ready to go so that when the patient arrives at the hospital, they can get from door to cath lab in the least amount of time possible. The goal here being that within 60 to 70 minutes of the person experiencing the symptoms, they can already be in the cath lab getting whatever treatment is necessary to reperfuse them. So it's important for us to use the EKG to get that rapid identification of an acute myocardial infarction or other related cardiac event, and then to work through the system so that they can have the least amount of time possible before they get treatment. Pre-hospital 12 leads tend to reduce the time to in-hospital treatment by anywhere from 30 to 60 minutes, which is huge. That can mean that can mean a whole lot in relation to the patient's outcome and their morbidity when it's all said and done. When we look at the EKG, the EKG is a system of vectors. Vectors is what we're referring to as directional electrical activity. So a vector is a way to show the strength and direction of the average electrical impulse. So I'll talk more about that a little bit later. And each cell gives rise to its own electrical impulse. So that means if we have a cell here that has a gap junction to a cell here, and this cell is initiating the signal, then that means the vector is going that direction. When we see a whole bunch of cells, like say I have cells, all of my fingers are individual cells, and I have my whole arm over here is full of cells, and all of these are firing, and all of them are leading to the cells over here to cause them to fire. Our general vector is still in this direction, okay? But I might have cells here. I might have some cells here that are firing up. I might have some cells here that are firing down. So the vector is the average conglomerate of where all of the electrical activity is traveling, generally speaking. And the intensity and direction of each of those vectors is dependent on physically where those cells are located and which cells are firing. And we literally have a few million different individual vectors, and then we have kind of an overall heart vector, which will be the compilation that we call EKG here pretty soon. So the vectors represent the amount of energy and direction, and they add up or subtract based on what's going on. The EKG is just a picture of the average electrical activity of the heart. So depending on which direction these vectors are going will kind of tell us what the overall general look is of the heart. And I'll make that more clear as we go along. Whatever the overall average direction of electrical activity is kind of what we call that final vector. And that final vector is what shows up on the EKG and gives us what's called the electrical axis of the heart. And the electrical axis of the heart is what we're calling the general electrical flow in the heart. So what is the general overall electrical flow in the heart? So right in this particular picture, this rainbow colored arrow is showing you the axis of this particular heart. And that arrow could be pointing in any number of different directions, which tells us the axis is moving or that the axis is in a different direction for some reason, and we'll discuss that as we go. And each individual wave, the P wave, the T wave, the ST segment, the QRS vector, they all have their own independent vectors or their own independent axes as well. We'll discuss how to find out what the axis is, what is that electrical activity doing, and what does it tell us in the end. But an EKG is the overall measurement of all the vectors added up as they pass under an electrode. So electrodes and waves, when we have, so an EKG has a negative electrode and it has a positive electrode. Later on, I'm gonna help us to kind of visualize that the positive electrode is a camera, and the camera is always pointing at the negative electrode, and the electrical activity of the heart happens in between. And whatever flow of electricity that's happening in between shows up as a waveform in some way. So if we have a camera on a positive electrode staring at a negative electrode, and we have a positive impulse moving away from that electrode, we see a downward spike on an EKG. So I want you to get away from thinking up and down as being good or bad. It just tells us whether the electrical activity is traveling towards or away from a given electrode. So if we have a positive impulse, and when I say positive impulse, think of depolarization, right? Depolarization is a positive wave. It's caused by either sodium or calcium entering a cell of some sort, right? This is something you learned in your first term of AMP. So it's a positive wave already. So when we have a positive depolarization wave moving towards our electrode, our positive electrode, towards the camera, then we see an upward deflection. And if we have the waveform traveling perpendicular to the line that is made between our positive and negative electrodes, then we see a waveform that is equally positive and negative. So that's kind of the general idea, and I'll try to find you some ways to illustrate that when we get into some of the labs. So in our EKG, we have two electrodes. We call them bipolar leads. We've got a positive one and a negative one. The camera always sits on the positive and is always pointing to the negative. If the electrical activity is traveling towards that positive, then we see an upright wave on the EKG. If it's traveling away from the positive, then we see a downward deflection on the EKG. And if it's traveling perpendicular to the line that is created from that camera looking from the positive to the negative, then we have one of two things, either one that's equally positive or negative, or we actually don't see anything at all and it's a little bit of a flat line there. If we do see an equally positive and negative wave, it's always going to be very, very small. So very small or non-existent at all. So as we look at this, again, I want you to start thinking of an EKG as a system of cameras that are just taking pictures of the heart. We're getting multiple pictures of the heart, and because we get multiple pictures of the heart, we're able to create kind of a 3D perspective that we can visualize. If we had sophisticated enough software, we could input an EKG and have it draw us a heart on the other side. So we get a 3D picture of the heart, or at least a 3D perspective, by looking at a whole bunch of cameras of the heart. And in a 12 lead, we were looking at 12 pictures of the heart. So that's where that comes from, right? The information that we get tells us things about the normal physiology of that person's heart, and it tells us about any pathology that they might have, or any problem areas in the heart that we need to address and help to fix. So we have a couple of systems. The hexaxial system of the heart is the system that's created by what we call the limb leads. These are the EKGs that you're putting on the shoulders and the legs, or the wrists and the ankles. So the hexaxial system actually has 4 leads. Einthoven originally just had 3 wires. He had a positive wire, a negative wire, and a ground. And because he had a positive and a negative and a ground, in order for him to get different views of the heart, he had to physically move these wires around. When EKGs first came out, and we had these same 3 wires, we did have machines that were sophisticated enough to switch what each of the wires did. So we could switch which of the wires was the ground, and which of the wires was the positive, and which of the wires was the negative. But in the end, we could still only get 3 views of the heart. After a while, we realized that if we added a wire, we could put a universal ground someplace, and then what we had a positive, a negative, and then 1 wire that's just hanging out. And that's going to help us a little bit later. So the hexaxial system is a system that takes the heart in the coronal plane, and it gives rise to what we call the 6 limb leads, which are leads 1, 2, and 3, and AVR, AVL, and AVF. And each of these leads are 30 degrees apart, and that'll become important later when we talk about axis. So the vertical leads, or the hexaxial system, has 4 wires, and it allows us to get 6 different views of the heart. I'll explain how that is in just a minute. And this picture that you see here represents where the camera is lying. So our lead 1, for example, has the camera here pointing directly through the heart to its negative, which is over here. Lead 2 is our camera right down here that points up to its negative right over here. Lead 3 is in the bottom right of the heart that points to its negative up here. Then we have AVF that points in this upper left area of the heart straight down to its negative. We have AVL, AVF that points directly up, and AVR that comes from the top right down. And all of those cameras are all 30 degrees off from each other, and that'll become more apparent a little bit later as well. So when Einthoven did this, you know, he was just trying to figure things out as he went. So the first thing that he did was he had the right arm be a negative, the left arm be a positive, and the left leg be a ground. And because that was the first one that he did, that became our first lead 1. Shifting around, he had the left leg as a positive, he left the right arm as a negative, and put the ground on the left arm, and that gave us our lead 2. And then when we had the left leg as the positive, the left arm as the negative, and the right arm as the ground, that became our lead 3. And for a long time, we just shifted between those 3 leads. Then someone had the bright idea that if we were to, well, let me go back to this picture. We had the bright idea that if we added a lead onto the right leg and made that a universal ground, then the other 3 wires could be used for anything we wanted. Now, if we used them in the same places that Einthoven did, the negative on the right and the positive on the left arms, we had lead 1. The negative on the right and the positive on the left leg was lead 2. And the negative on the left and the positive on the left leg was lead 3. If we continue to do that, we still had 1 wire that was hanging out not being used. Well, what we found out is if we take that 1 wire and polarize it negatively, and so if we take over here, if you see my arrow, if we take the right arm and make it negative, and the right arm and make it negative, and the left arm and make it negative, and make them both equally negative, it took the camera that was down here on the left leg and made it look right in between, because it was equally attracted to both of those negative signals. So all of a sudden we had a different view of the heart that we hadn't had before. So if we walk around and do that with all of them, if we make this right arm positive and both the other leads negative, then we get to see right down through the middle here. And if we make the right arm and left leg negative and the positive up here to the left, we get to see this view here. So all of a sudden we got to see different views, and we call those the augmented unipolar leads. Augmented because in order for us to actually see things in the same ratio as leads 1, 2, and 3, we needed to augment the 2 negative leads so that the pull on the camera to that middle section is the same as any other negative lead if it was a single lead. And it gave us the views from the left, the foot, and the right. So AVL stands for augmented voltage left, AVF is augmented voltage foot, and AVR is augmented voltage right. And now we get to see 6 views of the heart instead of 3 by just having 4 wires. Then we have the precordial system. And by the way, I'm going to go back over all of this as we actually set these up on each other later in future classes. The precordial system are a system of unipolar leads that travel around the chest cavity. There are 6 electrodes that we're placing on the cavity, and the machine, the EKG machine itself, is calculating a pseudo-negative location. It's basically trying to calculate the center of the heart, and that center of the heart becomes the negative where each of the positive electrodes is pointing its camera. And we call that Wilson's terminal, that common negative reference point in the center of the heart is Wilson's terminal. And so we have V1, V2, V3, V4, V5, and V6 that travels around the heart, and specifically around the left ventricle of the heart in the transverse plane. So our limb leads, our 4 wires on the limbs are on the right arm, right leg, and left leg, where the right leg is the universal ground. And the precordial leads travel around the left ventricle, where V1 and V2 are on either side of the sternum in the 4th intercostal space. V4 and V5 are in the rib space, V4 is in the 5th rib space on the midclavicular line. V3 splits the difference between V2 and V4. V6 is in that same 5th rib space that V4 is, but it's on the mid-axillary line. And then V5 splits the difference between V4 and V6. It's also in the 5th rib space and should actually be somewhere near or on the anterior axillary line. And so that travels around our left ventricle for the most part. We'll do these in class. You'll be setting these up on each other, and you already did them in EMT, but you'll be doing literally hundreds of them over the course of the year as our course continues. So all of these pictures gives our heart a 3-dimensional picture. If we're cutting the heart both in the coronal and transverse planes with all of these different electrodes that we see on a 12 lead, we get a nice 3D picture of the heart, and we can really identify where damage might be. Then we name them. So they're all named anatomically. So if you're looking at the heart, if you're looking at the bottom of the heart, we're looking at the inferior portion, and leads 2, 3, and AVF all look at the bottom of the heart. So we call those inferior leads. V1 and V2 are right at the septum between the right and left ventricles. So we call those septal leads. V3 and V4 are the anterior leads. And then leads 1, AVL, V5, and V6 are what we call the lateral leads. AVL we often refer to as high lateral. Please note that even though V3 and V4 seems to be off to the side, we call those anterior. Anatomically, go back to your A&P for just a minute. Remember that the heart is not situated where the intraventricular septum is directly on our midline. The heart is actually tilted a little bit so that the right ventricle actually is on the anterior portion of the body. Then we have the intraventricular line, and then the left ventricle actually juts off to the left and to the posterior of the heart. So you just have to remember how the heart is anatomically placed in the chest, where the right ventricle takes up the anterior view more than anything else. Okay, so that's kind of an overview of EKG and what EKG actually is. Let's do one additional thing here for just a moment before I stop our recording. So just talking about EKG itself, the paper and the tools that we use for a second. With the EKG, the paper is measured in millimeters. So there's little millimeter squares on them, and each of those millimeter squares has a meaning. So height is measured in millimeters, and that lets us know amplitude of the amplitude of our signal, of our depolarizing signal. The width is measured in milliseconds. So from left to right, time is going by in milliseconds. The EKG passes under a pin at a rate of 25 millimeters per second. What that means is that if we have millimeter square boxes, each small box is 1/25th of a second, or 0.04 seconds. Yep, that's something you need to know. Each little box is 0.04 seconds. That means each 5 little boxes make up 0.2 seconds, and each 5 seconds we have thicker lines, so we see big boxes and little boxes on our EKG paper. The little boxes are millimeter squares, and the big boxes are 5 millimeter squares. So each little square is 0.4 seconds, and each big square is 0.2 seconds. 5 big boxes make up 1 second. So that time is going to be important. Each lead on an EKG is on a 12 lead EKG is 2.5 seconds long. So a full 12 lead EKG takes 10 seconds to run. So when we look at this, if we pull out a little area, each one of these little boxes is a millimeter square, 1 millimeter in height, 0.04 seconds in time. Each big square is 0.2 seconds. And then on a 12 lead EKG, each section of the 12 lead EKG is 2.5 seconds long. Time is ticking from left to right for a total of 10 seconds that our EKG, our 12 lead EKG takes. Now we're going to look at a whole lot of single leads before we get too far into looking at a bunch of 12 leads, but understand the timing is still the same. We also will have a calibration box at the end of a 12 lead, usually at the end of the 12 lead. And it tells us what is happening. The calibration box should be 10 millimeters high and 5 millimeters wide. That calibration box tells us that we are in the standard format where the paper is traveling at 1/25th of a second, and the millimeters are at the appropriate height. We might have a couple of different things though, right? We might have one that looks like it has a stair step, or we might have one that seems like it's twice as wide. Those are for different reasons. So if we have half standard calibration, it's because sometimes we have an EKG that has, we look at the EKG when we first run it, and it looks like the QRS complexes are running into each other. So the EKGs on the top are running into the ones on the bottom, or vice versa. And we can't, it's a mess. We can't quite see it. So what we do is we do a half standard. And what that does is it makes all of the EKGs smaller in amplitude so that we can actually see them. We have to note that though, because we do have some measurements where we're talking about hypertrophy and such, where that measurement in millimeters is important. And we have to make sure that we know if we're seeing the actual height or we're seeing the half standard height. So this works really well if we have rhythms that are running into each other. And then the 50 millimeters per second calibration is where we see that box that looks twice as big as it's supposed to, twice as wide as it's supposed to. This is really important for sometimes fast rhythms. Sometimes rhythms are going so fast that the QRS complexes are really close to each other. And if we put it at 50 millimeters per second, it runs the paper slower. So if the paper is running slower under the pin, then it acts as if it's slowing the rhythm down. And we can actually see a little bit more of what's going on in between the two QRS complexes. Again, it's important for us to note if that's the case though, because when we're calculating rate or something to this effect, we have to know if we're at halftime or not. So lead representation is almost always the same on pre-hospital EKGs. Hospital EKGs, you might see something slightly different because of the way that we can stack it. But on a pre-hospital EKG machine, the layout of the EKG is almost always this way. So what you see here, we almost always see these top 3 lines. Well, we will on a 12 lead always see these top 3 lines where it's always set up this way. Leads 1, 2, and 3 make up the first column in that order. AVR, AVL, AVF make up the next column in that order. Then V1, V2, V3 is the third column, and V4, V5, V6 is the fourth column. some of our pre-hospital EKGs will also have a rhythm strip down at the bottom that is one lead all the way through. That can be pretty useful because it helps us to kind of compare a bunch of things on the EKG. And some of the EKGs have that and some of them do not. It's really beneficial if it does, but it just depends on the type of machine that we have on what it does there. The temporal relationship is always the same. In other words, when we look at a 12 lead, what's happening up here in lead 1 at that same time is happening down here in lead 2. In other words, leads that are on top of each other, you can never have a P wave happening in one of the leads and a QRS complex happening in the other. If you see a P wave up here in lead 1, you'll also see the P wave in lead 2 and in lead 3. So that relationship is the same. Remember that time is ticking from left to right. So at a given time, it is that same time on each of those particular leads. And then when we talk about kind of the view of things moving left to right, realize that in the first column, top line, we have lead 1 in the first column and AVR in the second column. They will look pretty different, but the EKG is still ticking from left to right. And if we have that bottom rhythm strip, then we would see it go the same all the way through and be able to compare things and look at things in certain ways. So this temporal relationship of looking at things is really important for us to find and look at P waves or QRS complexes or ST segments. It's really important because it helps us to evaluate what's happening in a different area of the heart. There's a variety of tools. In our class, we're going to use calipers and also a ruler or a straight edge. We'll supply the ruler that I want you to use and the calipers. You should find calipers. You can order EKG calipers from almost anywhere, but you'll want to have your own EKG calipers. And you want EKG calipers as opposed to like mapping calipers or mapping compasses. So because we want 2 pins on the caliper, not one that has a pencil on one side. And you want them to not have the pinwheel in the middle that locks them in place. You want to be able to easily move them open and close. There are other tools out there, axis wheel rulers that you can get, or other types of things that give you information. In our class, you're going to have to calculate everything and learn how to calculate everything. So we won't let you use those kind of cheating tools. They are useful on scene in a lot of cases, but for the purposes of the class, you have to learn how to do it manually first. So on all of our evaluations and exams and that kind of stuff, you'll have to be able to use your own. Calipers are going to be your biggest tool. They're fantastic. We use them to do all kinds of different things, from measuring objects to identifying rate, using ratios of amplitude. All of those kinds of things come into play. So calipers are great. Sometimes you want to take a look at something on a dirty part of an EKG, but you can move it to a cleaner part to get actual measurements. Sometimes you want to walk it through to see if you have even timing on something, or if something is the exact same width wherever you go on the EKG. So it becomes really important, and your most important tool when we talk about analyzing EKG. Sometimes we'll want to compare heights. So sometimes we're going to say something like, hey, the height of the Q wave is greater than 1/3 the height of the R wave. So therefore, you need to kind of be able to check and see those ratios. And sometimes counting boxes can be a little blinding. So being able to use the calipers to identify the different measurements is pretty important. Sometimes we're going to add, so for example, the EKG, when we want to know the amplitude of total activity in the EKG. And so sometimes we'll want to add the EKG together, the QRS complex and the and the Q wave or the S wave or something to this effect. So again, we can be able to use it as a measuring tool. So a lot of different uses for the EKG. Comparing widths will help us to identify certain types of blocks or aberrant beats, this kind of thing. The axis wheel ruler, again, we're not going to use in class, but just be aware that it's available. And sometimes when you go out and buy an EKG book, it comes with it. So it's one way to help you kind of do a cheater method of getting the axis. You'll have to learn how to calculate it in this class. Same thing with an EKG ruler. We're going to give you a ruler that that will have you use in class that doesn't have a lot of information on it on purpose. But there are rulers that have tons and tons of information on it, again, that you might get from your EKG material when you purchase it. This is going to be similar to what we're going to give you, is a straight edge ruler like this. It'll be translucent so you can see through it. And having that blue line in the middle is really helpful to helping us determine a baseline and where that baseline happens to be. So this ruler is something that you'll be able to use in class. So those are the tools. So we talked a little bit about the EKG and the, stop sharing here. We talked a little bit about the EKG, just generally speaking, and then talked a little bit about the different tools that you're going to use as we start to measure EKG. So that's all an introduction to where we're going. Next, we're going to start talking about what the actual beat looks like and what it actually means. And we'll start moving forward pretty quickly with EKG. Take the time to go back and review your anatomy and physiology of the heart. You cannot know that enough. Those of you who have been around and I've had a chance to talk to, and especially if I had a chance to talk to you when you were taking your AMP, you'll recall that I always said to take your AMP for the purposes of learning, not just for the purposes of getting a grade. You've got to know your anatomy and physiology. And it's critical that you have the anatomy and physiology of the heart nailed before we walk into learning EKG. If anatomy and physiology is something you're struggling with about the heart, then you're going to be struggling with EKG as well. So jump on that quickly. If you have any struggles, let me know well ahead of time. Let Chris know well ahead of time, and get help as soon as you possibly can. All right, that ends our second video.